Bonjour à toutes et à tous. Hi everyone, c'est avec grand plaisir que je vous accueille dans ce dernier séminaire d'une série de 5 ateliers sur les frontières qui s'est étiré au cours de l'hiver à la chaire Raoul-Dandurand. My name is Elisabeth Vallet. I am the director of the Center for Geopolitics of the Raoul-Dandurand Chair in Strategic and Diplomatic Studies at the University of Québec at Montreal. And it is my pleasure to welcome you to this last roundtable of the semester on border issues. Of course, as you all know, in the wake of the WHO declaration of the pandemic nature of COVID-19, we've seen one state after another seal its borders more or less tightly as the virus spread. So, au plus fort de la crise, en mars 2020, 91% de la population résidait dans un pays qui avait mis en place des mesures de limitation des franchissements frontaliers. We had citizens seeking return to their countries, temporary residents and migrants caught in no man's land. So the fight against the viral and yet invisible enemy has been mobilized to implement a set of emergency policies, and that has had an impact sur la santé, bien évidemment. We've seen that we've used border fortification in history, such as the Wall of Plague in the 18th century, as a mean to contain a virus. On sait aussi que ça fonctionne pas toujours. Alors, la santé est depuis toujours au confluent des frontières. Et pour parler de cette question, dans un contexte où la pandémie a ajouté un degré de complexité, nous avons 3 spécialistes de ces questions frontalières et de santé. So, in order to discuss this very important issues, we are happy to have with us, first of all, appointed as Quebec's delegate to New England in May 2014, Madame Marie-Claude Francoeur serves as Quebec's representative in Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. This is her second term in Boston, and Madame Francoeur's career is one of public service, working to shape and promote Quebec's policy on climate change, on energy, transportation, labor, francophonie, both at home and internationally. So, vraiment un mandat très complexe. On est ravis de vous avoir ici, Madame Francoeur. Merci d'être là. Dr. Eva Moya is Assistant Professor of Social Work at the University of Texas at El Paso, the beautiful town of El Paso, but also with many and complex issues as it is a border town, where she works on access to healthcare and health services for transborder communities, homeless women, and Latina women. Gracias, Dra. Moya. It's a pleasure to have you here. And finally, last but not the least, Andréanne Bissonnette is PhD candidate in political science and fellow researcher at UTEP, former fellow researcher at UTEP. Her research focuses on access to healthcare, immigration, and borders in the United States. She has very stimulating research in her hands. So all 3 of you have accepted to collaborate in that conference. Thank you very much. So to the 3 of you, through your work and your research, you all look at different dynamics at both the US-Canada and the US-Mexico border. With COVID-19 and all the border closures, how has healthcare access or healthcare collaboration been impacted? And how does the reopening of the border is marked by these experiences of collaboration? Maybe just to start with, maybe a wider question, Madame Francoeur.
Oui, merci beaucoup. Alors, bonjour à tous. Il me fait grand plaisir d'être parmi vous aujourd'hui. J'aimerais profiter aussi de l'occasion pour remercier la chaire Raoul-Dandurand et particulièrement Andréanne Bissonnette d'avoir pensé à la délégation du Québec à Boston pour présenter nos collaborations régionales en santé. C'est très apprécié de savoir que vous reconnaissez ce que l'on fait de bien et, comme vous le verrez, ce que l'on fait différemment. The closure and eventual reopening of the border are, of course, a federal matter. However, the sanitary measures put in place are the responsibilities of provinces and the states, as you well know. When the border closed last March, the Quebec government was quick on its feet to reach out to its New England neighbors. Together, we created a COVID-19 response task force. Since then, we've been meeting about once a month to discuss the evolution of the pandemic in our respective states and provinces and the sanitary measures put in place. As time went on, we discussed economic reopening plans, best practices and policies, return to school, and other measures. Now we focus on vaccination rollout and what happens when the border eventually reopens to non-essential travelers. We want to be able to inform our populations of the measures and restrictions put in place on both sides of the border to ensure a safe and smooth travel experience. The main purpose of this group is to make sure that we have an open channel of communication so we can share information effectively and efficiently so we can better prepare and respond. Through this open line of communication, we have been able to quickly and effectively deal with everything from agricultural inspections to cross-border transactions in a timely manner that kept people safe, ensured commerce continued to flow freely. In the past few months, though, especially on the US side, elected officials have started putting pressure on the federal governments for reopening of the border. In addition to these demands, some states have put in place measures to help Canadian citizens get vaccinated and speed up the border reopening. I'm not telling you anything that you don't know, that vaccination is key to an eventual border reopening. So I will give you a few examples of those cross-border measures. The first one hails from North Dakota. So last April, North Dakota Governor Doug Burgum and Manitoba Premier Brian Pallister announced a new initiative called the Essential Worker Cross-Border Vaccination Initiative, where North Dakota will administer COVID-19 vaccinations to Manitoba-based truck drivers transporting goods to and from the United States. This is the first such program between a Canadian and an American jurisdiction. This vaccination initiative is an opportunity to strengthen that bond by offering assistance that will protect public health and the flow of goods and services on both sides of the border. The shared goal of this initiative is to create a model, a continental cooperation for others to emulate as we prepare to safely reopen our shared border. The second example is from Vermont. On May 7th, Governor Scott announced that any out-of-stater who works in Vermont is eligible to get vaccinated in the state, regardless of their profession. The new eligibility is an expansion of previous eligibility that allowed out-of-state college students and part-time Vermonters to get the vaccine. Out-of-staters who work in Vermont can either register on the state's website and set an appointment or attend a walking vaccination clinic. The most recent example that comes to mind came out of the recent meeting of the New England Governors and the Eastern Canadian Premiers Conference that was held on May 17th. And it was attended by all the governors and the premiers of the 4 Atlantic provinces and the Minister of International Relations of Quebec. All of the participants expressed concern about the pace of the vaccination campaign on the Canadian side, which could hamper economic recovery efforts. They therefore agreed to appeal to their respective federal governments to ensure that the surplus vaccines are sent to Canada. This approach would promote a stable and timely economic recovery and greater and faster access to vaccines for the Canadian population.
Thank you very much. It takes a while to get back to my mic. Dr. Moya, how's healthcare access and healthcare collaboration been impacted by COVID-19, and how do you see, the months coming with maybe the opening of the border?
Thank you so much, Elizabeth and esteemed colleagues, for the invitation. And that's a loaded question. Had we asked the question back in April, probably the answer would be a little bit different because we didn't know a lot of things. But it's been clear that for the last 15 months, we've seen what the haves and the have-nots look like, things that we already knew but have been magnified as a result of the COVID impact, primarily on underserved, uninsured, and very vulnerable populations. So on one hand, the US-Mexico border region got hit with COVID a little bit later. So we saw it coming, as we sort of looked through New York and we saw sort of the numbers accumulating. The border continues to be pretty much isolated. I'm talking about the US-Mexico border, primarily the 2,000-mile long stretch, the 100 kilometers north and south that really bring together the 4 states on the US and the 6 on the Mexican side. But when COVID finally hit our communities, it hit bad. Why so? Because we primarily live in a region that has limited infrastructure, healthcare-wise, with the exception of San Diego, which is much wealthier than almost any other border counties on the US side. We have the highest uninsurance rates of the country. If we were to be made actually another state in the United States, we have a disproportionate number of health professionals. All of the areas with the exception of San Diego basically are medically underserved and underrepresented. So you're looking at a region of the world that already has significant poverty, high uninsurance, limited infrastructure, limited access to providers, got hit with a pandemic for which we knew very little. Second, we didn't really have adequate testing in place that looked like a response that could have been a binational response, but then it wasn't. So I want to pause to say that our border region has been struggling, for the last 100 years or plus in trying to find mechanisms so that we could communicate, talk to each other, collaborate, come to terms to address, issues, whether it is tuberculosis or whether it's a disproportionate amount of diabetes or whether we have, a trend of syphilis, but nothing like the pandemic. I think that COVID has really put pressure on both governments at localities, municipalities, and counties to come together to do more and do better and do so differently. The tightening of the US-Mexico border, the closure of the border to the non-essential travelers, that means anyone with a tourist visa or with a pasaporte local, as stated in Spanish, has restricted thousands of individuals that really depended or worked in the United States and are now on the Mexican side in an economy that necessarily is not willing or open or given the COVID restrictions that embraces. So we have seen higher unemployment on both sides of the border. It's beginning to sort of like dip a little, but not enough. But my colleagues on the Mexican side, in my opinion, are being hit the hardest. Second, hospitalizations have continued to be high, with the exception of the last few weeks. The numbers have been dropping in El Paso significantly for COVID, hospitalization and COVID cases. However, when I look at the number of cases, or individuals affected in Ciudad Juárez, which is the border city to El Paso, population of approximately 2 million, depending on who you ask, okay? The data as of this morning claim recorded cases, 31,731 individuals that have tested positive for COVID, with 3,381 accounted for as death. So mortality on the Ciudad Juárez side is huge. And my take is that there's probably an undercount. And then second, when you look at the number of individuals that have been impacted by COVID on the El Paso side, our population is close to 800,000. It's about 136,000 that have tested positive, of which we have had mortality of 2,620. So what does this mean? It means that both communities are suffering. It means that what happens to one really hits the other. It means that especially it's very difficult for immigrant, migrants, asylum, refugee populations that are being trapped on the Mexican side and that are not necessarily Mexicanos and Mexicanas, but that's where now home is. It means also hope because of the changes in administrations, in our country, the possibility of beginning to open up and free and become much more efficient in trying to move refugee and asylum applicants that have been waiting for close to a year, year and a half, or almost 2 years, to begin to finally cross legally so that they can be ideally, placed in sponsored homes, and that they can begin to be connected with courts so that their situation could be improved. At the end of the day, the burden has been high, especially on communities of color. What does that mean? In my community, that means primarily Hispanic, Latinos, Latinas, and that is about 89% of the population. And if you go a little bit outside of the El Paso region, that's probably 95% of the population. And so I think we have our work cut out for us. I think this is the type of social, public health, and political event that really challenges governments, and that I do hope that governments and communities and all sectors do come together to do better. Because if we can tackle conditions such as COVID, we can tackle almost anything and everything. And my position in life is that two countries could be twice as powerful and effective if they're able to come together to speak a common language. And the common language here is protecting people's health. So We can talk about testing, we can talk about vaccines, the haves and the have-nots, but those are some general first impressions.
Absolutely. There is this illusion that if you close the borders, then you don't see what's on the other side, and it becomes totally external, almost foreign, but it's definitely not the case. You're right. Maybe Andréanne, Andréanne Bissonnette, since you're looking at both borders, I would like to have your take on that.
Yes, so as mentioned by my colleagues, COVID-19 has surely impacted healthcare access on both sides of the border, whether at the US-Mexico border or at the Canada-US border. But there has been disparities in collaboration between the two US borders. As Dr. Moya mentioned, at the US-Mexico border, there has been less collaboration than some have highlighted at the US-Canada border. For example, in the Windsor-Detroit region, there has been an increased recognition of the importance of daily mobility and deep links between the two countries, between the two communities. For example, about 1,600 healthcare workers live on the Canadian side of the border, but actually provide care in Detroit, so on the US side of the border. And their continued cross-border movement has been essential in the response to COVID-19 in the Detroit region. And that has translated in another example of collaboration in that specific region that has just been announced in the Canadian media outlets in the last few days, with the mayor of Windsor actually pushing for an initiative where Canadians would line up in the tunnel that is linking Detroit and Windsor, and US pharmacists would line up on the other side of the border in the same tunnel, and vaccines that were not dispensed to people in Detroit that were about to be thrown out would be given to Canadian citizens that are waiting for their second doses, as the rollout in Canada has been somewhat a bit slower than in the US with regards to the second doses, as government decided to push back second dose to inoculate the majority of people with their first doses. So that has been something that, as Dr. Moya mentioned, that could be a potential of collaboration is now being tested along the US-Canada border, and could be an example for future collaboration between border communities, either at the US-Canada border, but also along the US-Mexico border. But furthermore, I think border closures and subsequent articles and media attention to the dynamics of both borders has highlighted how daily life is impacted by border being open or closed along both borders, and how people actually access healthcare on either side of the border. So being either on the US-Mexico border, with some having a dentist on one side, physician on the other side, but also along the US-Canada border, where it might not be as salient how the disparities in cost could be present, but actually we have some of that same movement along the US-Canada border, with people accessing medicine in Canada from the US side, and people from Canada accessing care on the other side of the border. So as we enter a phase of reopening borders, I think these dynamics should be taken into consideration, whether it is a transborder vaccination sites or simply the daily movements of people to access care, and should be taken into consideration as we reopen borders and as we look forward to more collaborations between the three countries, and put an emphasis not solely on tourism and economics, but also on healthcare access.
Thank you. And you were speaking about the daily life in those border towns. Dr. Moya, you currently lead two research studies, one on HPV vaccines and the other on women's experience of homelessness in El Paso. And actually, you wrote a chapter published in Tony Payan and Pamela Cruz's Institutional Development and Governance on the US-Mexico border on cross-border healthcare. So definitely the heart of that table ronde. With the events of the last year, have you witnessed specific impacts on the homeless population in El Paso and on homeless and migrant populations in Ciudad Juarez, like specifically?
Yes, thank you. That's a really great question. I wanted to add also, Elizabeth, that we embarked in a binational research study recently. It's funded by the University of California, Berkeley, that now is looking at the experience of transsexual adults, migrants caught in either Juarez or El Paso during COVID times. So just when we thought we had complex, issues and phenomena of interest, here we come with a small award of $5,000 for the US side and $5,000 for the Juarez side to embark in a binational study looking at the use of photo voice as a participatory action research tool. So we're asking transgender women primarily to photograph their lives in the midst of policy, migration, disruption, being caught on the Mexican side, beginning to cross now legally into the US side. So talk about some of the most challenging research. I think this project has been one of the most challenging because recruitment of participants has been complicated. The resources and the assets that we thought we had to get to the networks and to the shelters are not fully there. And so we had to develop new relationships. We had to develop new approaches. We had to really find women that would trust us as researchers, but researchers with a consciousness to begin to have a conversation and a relationship with them to begin to then open up to the opportunity of documenting what their life has been. And so we're in the midst of that. We're almost done with the data collection. It is primarily qualitative in nature. And just asking the question, the open-ended question about how do you identify? Well, we can't group that answer because we have 14 participants on the El Paso side and then 7 participants on the Juarez side. And together we can make up a single category of how do they identify. So that has generated, I think, more questions for us. So that research is active. I have seen an increase on the home free or the homeless population on the El Paso side. When COVID struck our community, what ended up happening is that the city of El Paso finally sort of like took homelessness seriously because they really thought that it could represent a threat of infection and quickly moved some of the CARE COVID funds. Without the funds, it's very difficult to have the political will. So they quickly, gravitated to the largest shelter we have, which is overworked and underfunded. They took one of the recreation facilities for the youth and the seniors because every single recreation facility in El Paso was closed. And they transformed it temporarily for, 14 months into the Delta Welcome Center, where anyone experiencing homelessness could come in and be welcomed, be tested, be screened, be provided with shelter, possibly isolated. And what we found is some of the lowest positivity rates of COVID in the El Paso region. Fascinating. So the policy decision makers couldn't turn to the home free and say, you see, they are the ones that are bringing in the infection. It was the other way around. It was sort of like the society putting them at risk. Now, the center has closed effective mid-April. And what do we have now? What we knew what could happen. People are out on the streets. They're lost. The shelters don't have the capacity. And most of the individuals out on the street are not native of El Paso. So they're coming from other communities in the US or other countries. But they're finding this community to be a caring and loving community, and they're feeling somehow comfortable here. So we have our work cut out in terms of trying to learn from the lessons that we had in the last 14 years and calling on the city, calling on the county, calling on the private sector, calling on shelters to do things differently. Given that COVID revealed that we could break through the silos. We can, if we have the political will to do so. For migrants, it's even tougher, Elizabeth and colleagues, because if they're trapped in Ciudad Juarez, I'll just give you quickly an example of what I saw last week when I visited one of the 13 shelters in Ciudad Juarez. And these are not governmental shelters. These are shelters that have been put together because there is philanthropy and there are people that care, or there are churches or parishes or advocates or investment from the US or other countries. And so in one of the facilities called Respetrans, there are 185 guests, migrants, immigrants, refugee, asylum applicants. Out of the 185, 85 or so of them are children and youth. The remaining are parents. They're primarily coming from Guatemala, El Salvador, Honduras, a few Cubans, not a lot on this facility. And this is a facility that is run by a nurse who has 2 jobs, who basically does not get governmental support, and who is trying to provide for these families. The healthcare is almost absent. As much as I want, and I have great respect and admiration to my country, Mexico, in Constitution, everyone should have the right to healthcare. It's written into the law and into the Constitution. The reality is that today, our brothers and sisters who are migrant immigrants, even Mexicanos, they don't have the resources, cannot get adequate access to primary healthcare. So we have our work cut out for us because we're in need of healthcare, we're in need of professionals, we're in need of mental health practitioners. We sometimes talk about limited access. Mental health, it's a luxury. And I am overwhelmed because I see even the migrants that are moving into the US. I got a text today from one of the participants of our project saying, we're going crazy. Just when we thought that crossing to the United States was going to be sort of like this dream come true, we find ourselves in a community, which is El Paso, which looks like an extension of Mexico, and we speak Espanol. But they see, we don't know what to do. We need guidance. It's like we're really going crazy because we have no idea, we have no control or agency of our lives. We're at the mercy of a system. So I'll pause there only to say that these are some of the challenges that we're seeing and we're having. Research, it's going to continue to take place, but not in the usual way. Whatever we learned, we have to sort of say we learned, we put it into place, but now we have to adapt and transform. To really be mindful and do the work that needs to get done. So yes, my research, the research that is funded is human papillomavirus research, which is fantastic. But by the way, the HPV vaccine is not a top priority in people's lives. And even if we wanted to do vaccine work, right now the vaccine on people's minds is COVID. So how do we use our HPV research work to also do responsible COVID vaccine awareness? And how do we use the COVID vaccine funds and the recovery funds to ensure that we don't forget about all the other spheres of people's lives? This idea that it's funding only for COVID. No, it's funding for people's health. And so how do we ensure that we connect people with systems regardless of which community you're in? So those are some of the challenges that we're encountering.
+1 855
Huge challenges indeed, and we know El Paso is a special place, but yes, we've been wondering a lot about how we would have to adapt and transform your research and the way we do research, and I think you're shedding a light on what's coming up for us. Marie, I'll go to Andréanne Bissonnette right away because I think we're kind of touching on the same issues. Your doctoral research, Andréanne, looks at reproductive health access at both US borders. But you also recently, so maybe you want to speak about that before going to the chapter you've written on prescription drugs importation plans in the US and its reception in Canada. So you do compare 2 borders, and we can say that transborder healthcare is somewhat maybe not similar. I would like you to address that and maybe go then into the specifics of reproductive health and how COVID-19 has impacted these dynamics.
Yes, thank you. So initially, indeed, I'm doing my PhD on access to reproductive health for Latina women in the United States, but in terms of adaptation of research, I think the last year has been a good challenge. I actually had to switch the whole way I was thinking about doing my research in that sense. So I will be starting collecting data actually right now for my research, and initial answers to a survey that I'm currently doing highlight how important it is, especially along the US-Mexico border, to have access to both sides of the border to access reproductive care and to access care in a more general manner. So for example, contraception is available on both sides of the border, but on the Mexican side of the border, there are some options that are available over the counter, meaning that you do not need a prescription to access contraception. And that allows people who do not have regular access to a physician or to a family doctor to actually access their wanted contraception on the Mexican side if they are able to actually cross the border. And that is another issue that I'm looking at, is how trans-border access to healthcare is actually deeply anchored into one's ability to move across borders. So whether it is economic means, but also immigration status. So if you have the paper or if you don't have the paper, the border is actually either a resource or blocking some access with regards to healthcare, but also other aspects of daily life. So of course, closing the border for COVID-19 related reason has had impact on reproductive health access at the US-Mexico border, but also at the US-Canada border, because even though contraception, termination of pregnancy and other cancer screenings and other reproductive health care are available in both countries, some communities may be located nearer an hospital in one side or the other side of the border, but also there has been agreements between some provinces in Canada that do not offer some services to allow women to travel to the other side of the border. So for example, the Quebec government with New York has agreements for termination of pregnancy at later point in a pregnancy when the woman's health is impacted. But with the closure, it means that you have to prove that your travels are essential. And then there's the added impact of the border agents' subjectivity and discretionary power that can decide whether they deemed the service to be essential. And as we saw in the United States, some states have initially used that distinction between essential services and non-essential services to block access to reproductive care for women, deeming those services as non-essential in a pandemic, whereas they are time specific and need to be accessed at that point. So that is the main issue with regards to reproductive health access in a cross-border situation. It is very much so the discretionary power of agents, and also the fact that sometimes you have to do multiple travels within a short period of time, adding to scrutiny, and people have to put their body up for scrutiny both at the border and afterwards in the doctor's office for whichever service they are seeking. On a more general or more larger scheme of things, if we look at access to healthcare in a more general manner, I indeed just finished writing a paper on the US plan to authorize importation of medicines from other countries, more specifically from Canada. This has been something that has been discussed in Washington since the early 21st century, with most frequently bipartisan coalition of senators and of representatives that are pushing for a plan that would allow states to actually import medicines from another country. So let's say Canada negotiates prices with the pharmaceutical, and then the US buys those medicines from Canadian companies to sell on the US market. And there has been some support for the measure through the years, the last push being during Obama's presidency while they were negotiating Obamacare. And some wanted to add that into Obamacare, but the pharmaceutical push on the US government actually led Obama to switch side on the issue and block the measure in Congress, leading to the death of the measure. But during Trump presidency, it actually was brought back, especially by Ron DeSantis, the governor of Florida, who is a close ally of Trump, and pushed the government to initiate the process again through executive orders and through executive measures, leading to actually an authorization for the FDA, the Federal Drug Administration, to authorize plans by US states to import medicines from Canada. So actually what they're trying to do is that individuals can now move across border to access cheaper medicines either on the Mexican side or the Canadian side of the border. But right now, some states are saying we're not located at the border, or we're located at the border, but our citizens cannot move across states. So we want to actually bring this to a way larger level. And it wouldn't be just one individual crossing border, but rather the medicines coming to the people instead of the people going to the medicine. And that would have a critical impact on Canada. And it is something that has not been discussed much in the US, how it would impact other patients, because pharmaceutical would not drastically increase the amount of prescription that they send to Canada, knowing that they would be selling them at a cheaper price to the United States, but rather might say that they would cut short the supply for the Canadian companies, and thus impacting a situation where Canadians are already facing some shortage of prescription locally. So that is something that is very much important to look at. So the difference between individuals crossing the borders to get medicines versus bringing the medicines from Canada into the general territory of the United States, especially as Biden announced just last week that he supports the plan. So there won't be a reversal of Trump's decision on that matter.
Very interesting and a very gloomy days ahead in terms of access to medicine on both sides of the border, actually.
And especially just to add a little bit, so there's it's actually to lessen the prices in the US, which is a good goal, but it's actually just putting a Band-Aid and it's not a long-term solution.
Absolutely, because with a shortage, we would think that the prices would increase, and in the end, like both sides of the border would pay for that. That's interesting. And with Madame Francoeur, we kind of get, as a Quebec's delegate to New England, you have we are adopting here a multi-scalar analysis and looking at the same subjects from a different angle. Through the years, you've worked with local and state officials on many issues, but as we were discussing with Andréanne, the issue of prescription and what will happen with that, there is one that may not be as salient and well known in Quebec, is the work of your delegation on health issues, including the opioid crisis and COVID-19. So what are the main issues that you have worked on, and what is the role of the delegation on these issues?
Thank you very much for the opportunity to discuss that important part of our work. Through the years, the Quebec Government Office in Boston has had a chance to exchange with New England states on a number of different issues. In addition to being neighbors, our populations are very similar. Our GDPs are similar, our level of service in the healthcare sector is similar, access is different, but it's only natural that we look to each other to share practices and learn from each other's experiences. So as you mentioned, one of the main sectors of collaboration has been the opioid crisis and the sharing of best practices and harm reduction policies, including safe consumption sites. So prior to the pandemic, the opioid crisis was the #1 public health priority for New England governors, and it remains a top priority. Indeed, a report released at the end of 2020 showed that drug overdose deaths have risen during the COVID-19 pandemic in Massachusetts and among other New England states. A report from the Massachusetts Department of Public Health shows a 2% increase for the first 9 months of 2020 as compared to 2019. The preliminary data translates to 33 more deaths. There are many suspected reasons for that increase. One is people are using drugs in a more isolated settings. They fear becoming infected with COVID-19 if they were to seek treatment. Women in particular don't want to leave their children who are out of school at home alone to attend appointments or programs. And there's also one treatment program in Massachusetts that does take people in who have tested positive for the coronavirus. So in the pre-pandemic days, my office organized multiple visits to Montreal's safe consumption facilities, including one for the former mayor of Boston, who is now the new US Secretary of Labor, and the current Massachusetts Secretary of Health and Human Services, Mary Lou Sutters. So Quebec has centered harm reduction in its approach to drug use and addiction, beginning with some of North America's first needle exchange programs, and more recently with the opening of safe consumption facilities. So for Mayor Walsh and Secretary Sutters, as well as other public officials who have visited these sites in Montreal, their view on the matter evolved greatly during their visit. With our organization in collaboration with the Ministry of Health and Social Services of Quebec, they were able to see firsthand how these sites have kept people alive. So building from these visits, my office later organized working sessions with public health officials from all 6 New England states. And for many attendees, this was the first time they had all come together in one place. Having our voice there allowed those with very different opinions on the matter of harm reduction to come together and discuss the facts. As I mentioned, the issue is still a top priority. Now that COVID-19 pandemic is under control in Massachusetts, our office has resumed talks with the Massachusetts Joint Committee on Mental Health, Substance Abuse, and Recovery. We are planning another delegation of elected officials and experts to visit the installations in Montreal and meet with the Quebec governmental representatives and experts of the supervised injection sites as soon as the border reopens. Another area of public health collaboration recently has been the legalization of cannabis. So the state of Connecticut asked Quebec's cannabis experts to review its legislation, legalizing the substance. So it's a two-way street all the way. In February, Quebec's Ministry of Health had a series of meetings with Massachusetts elder care policy professionals on greenhouse model of old age care as they study reform to Quebec's system. So these are only a few examples that show the depth of our relationship. We are neighbors, and we are there for each other no matter what. Whether it is firefighters from Maine responding to Lac Mégantic or our public health officials sharing strategies to keep our most vulnerable residents healthy. We're in this together. And as a government official, I work with strict guidelines and with a set of policies and strategies and action plans. These are all very standardized, but the beauty of our work as representation is that we have a lot of latitude on which these strategies we promote and how we promote them. We're fundamentally serving the Quebec population, of course, but we are also serving our host region and therefore promoting Quebec's policies on the international scene. So how can we help them? You know, what expertise can we share? What have we tried before that has worked? And if we have made mistakes and they're looking at policies, how can they learn from those and be on a faster track? So those are the kind of information and actions that we share with our neighbors.
And as we can tell, it is much needed. In the perspective of COVID-19, maybe I may have a more personal question. What do you fear in your work, the three of you? Is there something that because of the pandemic, but we haven't seen yet, but could be the biggest drawback that you fear that you fear you will have to deal with? Is there something in particular that looking at COVID-19 could, have an impact that would be substantial? Dr. Moya.
Wow, that is a wonderful question. That sounds like a dissertation or multiple dissertation questions.
Why? Yes.
I have fears, of course. When I look around and I say, what do I see? I see the haves and the have-nots being much more obvious. And I see, on one hand, communities and part of society that is more aware of those differences. However, I see the other side of society that says that's not my problem. So I see a potential tension between, well, whose responsibility it is to ensure that we close some of those gaps that have been accentuated as a result of what we're facing now. So for me, that's a constant fear. And if I add on top of that, this element of supremacist or privilege, or even more intensified racism that gets in the way on how people treat each other, I am concerned that what we see is pockets of communities and societies thinking that they have a privilege and others don't. And this idea that there's some groups of people that are much more valuable than others. And I am concerned, but on the other hand, I am I remain determined and hopeful that there is greater awareness of the isms that are getting in the way of people's well-being. So those things are like macro. I'm also concerned about the following. Intimate partner violence. On one hand, we seem to understand the power intersectionality in intimate partner violence and the big challenges we have. And yet my take is that we haven't seen the reporting that I think should be taking place on the violence that is being generated within household, in workplaces, and the type of abuses that are happening in work settings, especially among vulnerable members of the society that don't have many choices, like the overworked, underpaid, like the constant abuse. I'm worried about sort of like the impacts of human trafficking, because these are topics that almost no one is talking about. And so like they're like silent, but they're so obvious. I'm concerned about some of the public health gains that sometimes, you know, we feel so proud. My God, we have made headways, right, in terms of vaccine, only to find out that we have more anti-vacciners or people that are not necessarily all for vaccines. And we're excited and thrilled about the power of vaccines, but that's not necessarily a common language. So I fear for gains that have been made in some societies, communities, or countries, and what the losses or almost a paralysis of systems to address those gains are. I'm concerned about how women during the last 14 months, especially working women, head of households, have been sort of like almost returned to the house and have had to do even heavier lifting of their lives, only to find out that they had less now access to wealth, to opportunities, and that in some cases, the gains that we have made in terms of economic and social development may be hindered, especially in countries that have less opportunities, or in countries that are at war or in tension, or in countries where climate change and all the other forces around violence and catastrophe are moving people to migrate. And so I'm worried about those, and I'm worried about our mental health. And if we truly understand trauma and the impact of isolation, on one hand, there are incredible things that have happened as a result of COVID. And some of them are quite positive, and so they have turned into assets. But I don't see the infrastructure of mental health coming to the rescue or at the forefront, sort of like saying, okay, we're here. So silo mentality, I'm worried about, we have great wealth coming to other countries for COVID relief. And I'm worried that sometimes we don't put it to greater use, or that we don't really look at the return of that investment, because we can spend the rest of our lives supporting rental assistance. Don't take me wrong, you know, I'm committed and passionate to ending homelessness in my lifetime, but it's not only about rental assistance, it's much more than that. So yeah, so those are some things.
Absolutely. And violence is palpable everywhere. And it's interesting the way we can sense it in the street, in the workplace, almost everywhere. So you're right. And in vulnerable communities, it has a greater impact. And
if I may, Elizabeth, one more thing. And I'm also worried about sort of like this chronic stress, or the way that the stressors are getting under people's skins, and how chronicity of these conditions are eventually going to have a toll on people's health and quality of life, and how trauma may be triggered, and how little we know. On one hand, I'm worried about children's adverse effects, you know, or experiences that are probably going unnoticed, because the children are sort of like beginning to come back to school, but they're not fully integrated into school. I'm very worried about the children of the migrant, immigrant, refugee families that are going without school. When I look around and I see 180 families in a shelter, of which 85 children, most of them could be in school, and they're not in school. So what does that represent for these children? What are the things that they're missing in life? Food insecurity and more poverty. The differences between the haves and have-nots. And I think, Adriana, you mentioned this, reproductive health, my God. You know, it's like no one's talking about sexual reproductive health. It's like, okay, we don't have time for that. Like, what do you mean we don't have time for that? Look what's happening in Texas. The legislation, the laws that are being signed about restricting, you know, our choices, our ability, you know, to decide what are the things that we need and we want to do, are terrible. So I see, unfortunately, politicians taking advantage of the times and introducing very draconian policies, especially against girls and women.
And this is scary indeed. I was reading about that this morning, and it's hard to grasp the immensity of what's going on and the setbacks that we're experiencing, and trying to find maybe a common language. Madame Francoeur, you've been talking about that, like how much we need to find a common language. Is there anything, and I know you as the representative of the government, if I'm asking for your personal opinion, I'm putting you in maybe an awkward place, but is there anything that you dread about what will happen in the next month? Something that maybe you feel you will have to address more specifically than usual due to COVID-19, or is it, my question maybe is irrelevant?
Well, I think that most people have suffered. Families, I mean, New England is part of our DNA. We're families. We're not only just neighbors and business partners and allies. So there are a lot of families that haven't been seeing each other. There are a lot of businesses, small businesses also, that have suffered from the lack of tourism. We've mentioned it a little bit earlier. It's not pertinent to healthcare, but it'll be interesting to see how those come back and how they do it. So, we do have very much similarities in the way we deal with issues. Hopefully we'll be able to get the vaccine rollout quickly. But, we are fortunate that we are very similar as neighbors. And I think that it will be more, we'll only be able to see the depth of what has happened for people that haven't been able to see each other for over a year and a half. And that's probably something we'll find out soon after the border reopens and people start talking about it more openly.
Absolutely. I see what you mean. Andréanne, did you have a take on that question? Like, is there something that you will be looking at more precisely?
I think with political science background, I would say the politicization of health is something that I am very wary about, and I fear a lot of linking to what Dr. Moya was saying about all of these different issues. I think one of the thing that we saw in the last year is how governments and how ideology actually impact how we view an health crisis. What was supposed to be something of public health has become a debate between Republican and Democrats in the US, between those who believe in science and those who don't. And I think those line of fractures is something that could have a ripple effect on many more issues once COVID has ended, whether it's vaccine or other health issue and other health access dynamics, and how governments are actually going to use that to limit access to certain things that they do not believe in. For example, we see it right now with reproductive health, but will it be something that will be used by governments regarding their ideological affiliation to limit other type of access to healthcare as well?